You're watching Teaching Consultation Skills, produced by GP Supervision Australia and presented by Dr. Simon Morgan and Dr. Jess Wrigley. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
This is a topic of great interest of mine, and really just reflecting on the fact that this area around consultation skills, consultation models, consultation structure, I think has been neglected in GP training for decades. And it's really starting to emerge. But you guys, us as educators, as supervisors, I think we can be the vanguard of really putting this on the map in GP training. And by way of introduction, my name's Simon Morgan. I'm a GP here in Newcastle. My official title is the Education Manager. I'm managing the education here at GPSA. I also work as a medical educator, ex-GP Synergy and now RSCGP. And I'm coming from a Awabakal country. And there's a photo of our beautiful town here in Newcastle at the mouth of the Hunter River. And Jess.
Like you, I'm also on Awabakal country and I work in clinical general practice 2 days a week, and I'm a medical educator the other 2 days a week and 1 day off to try and catch up on that.
Thanks. Good to have you along. I'm really hoping to make this enjoyable and informative. We are really talking about this vehicle, this sort of mechanism by which GPs ply their trade, by which they do what they do. And it's fairly extraordinary to think, depending on how many patients you see in a day and how part-time or otherwise you are and how long your career is, we see as GPs up to 150, 200,000 consultations in a career. That's an extraordinary number. So it's imperative, essentially, for educators, supervisors to take a focus on how to do it well. And so often we unpack some of the skills that you see in the consultation, and we certainly talk about a lot of the content that occurs in the consultation, but we don't think of it as an entirety, as this vehicle by which we manage patients' problems. What makes an effective, safe consultation? We're going to talk about some of those skills. And obviously, you'll be taking some of this away for your own practice, hopefully, but most importantly, how you can educate registrars in the practice. We are happy to let you know that this is an RSCGP CPD approved activity. So the consultation, we're going to think about the consultation like this little building, and we're going to think about constructing something that's efficient and effective and safe. And when we build a little hut like this on the edge of a lake, I guess we need to think about the plans. We need to have some idea how it's going to flow. We need to think about the actual materials that go into it, the nuts and the bolts and the planks and the roof, and the tools, the way we put it together. And if you think about the consultation, the plans are very much the models, and our plans will be very much our individual take on how we consult. The nuts and bolts, the content, we're not going to take a focus on, but very much consultation skills, those processes. And that's what I want to really emphasize when we talk through the session. In the UK and in Ireland and in Europe, consultation models are very much more part of the way GP training has taken place traditionally. And I think for many registrars or recent ex-registrars, they'd be fairly unfamiliar with the sort of international models of the consultation that have been described in the literature. And these have been written about for decades. Maybe this is an opportunity to point you to the GPSA consultation toolbox, which talks about some of these models a bit more extensively. We're not going to put one over another, but just to say, I think they're really useful frameworks for registrars to know about. And so even if it's not a great passion of your own, I think saying these things exist and encouraging registrars at least to have a bit of an understanding of what's been described before can be really useful. I looked as preparation for this talk at the RACGP curriculum, very recently developed curriculum published last year, and found that one of the references they use in what I wouldn't describe as an extensive discussion of the consultation. It was somewhat buried, actually, so at least it's there. And it referred to this paper Of the papers that I would encourage you to have a look at, or certainly that encourage your registrars to have a look at, this is a good one because it really describes some of the models over time. This is a not unfamiliar term to many of you. The inner consultation was a text that Roger Neighbour, a British GP, wrote last century, which sounds a long time ago, but a few decades ago now. And he described, and I really like this, that the consultation is a journey, not a destination. And I'm hoping that kind of resonates with you, and particularly when you sit in with your registrars, thinking that are they actually trying to get to the end to kind of nail down that end point? Or in fact, are they experiencing the journey? Are they almost sort of relishing the trip as it goes? He described 5 checkpoints along the way. He does use a hand for the 5, and it's been a model that's been around for a while that people like to use. And there's a couple of particular areas I think that are worth flagging when we sit in and watch registrars work, or when they discuss their cases with us, and we can actually use some of those areas. And this is his hand, and these are his stages, and we don't need to go through these in detail. I do like housekeeping. I like to talk about housekeeping practically, and that is actually keeping your room tidy prior to the next patient coming. Having done a number of teaching visits, visiting practices, visiting registrars, sitting in, watching them work, and getting a sense of where some of the really big ticket areas of consultation skills may be missing. And Jess, I don't know if it's your experience, but yeah, it's not uncommon that patients come in and look slightly askance at the couch with some bunched up paper, or sort of a pillow slightly awry, and an untidy desk, or even some notes or something open. So I think that's an important practical housekeeping step. We will unpack some of these as we go. John Murtagh, I don't know that you'd actually describe this as a consultation model, but I really like his very simple 3 objectives of the consultation. This comes from page 2 or 3 or 4 of his textbook. To determine the exact reason, to achieve a good therapeutic outcome, and to develop a strong doctor-patient relationship. And if even those 3 points are prominent in your teaching when you're talking to your registrars about an effective, safe consultation, you're 80% of the way there. Ron Roth. Again, if anyone knows of Ron, he's a really lovely, very, very capable GP and GP supervisor from Victoria, who published this article just a year ago now as a new framework for teaching the art of general practice consultations. And he described 10 steps in the consultation. Again, some of you may know this model, some of you may be familiar and have read about it. And again, I'm not going to go through these. We're going to actually describe more a 7-stage communication approach to the consultation. But we are going to flag some of these points, including the wrap. And I really like that term, the wrap, which is that, bundling it all together, including the patient's perspective, making sure they understand. If there's, a couple of things I'd encourage you to read and follow up on after this session, this would be one of them. This is another consultation model called the consultation hill, where we prepare and we sort of ascend and we reach the summit. And as you can see, rather like hill, the doctor and the patient take in the air, reflect on the ascension. And then patients look a little bit more like this. And I imagine many of you are thinking, yeah, that's a lot closer to the representation than that lovely ascent of a hill. So we've talked about plans, we've talked about consultation models, and I think they're actually a really hard thing to use when we're seeing registrars work in practice and sort of overlay Neighbour's model or Ron Roth's model indeed, and say these things were missing, because of course every consultation is different. We see patients with primary diagnostic problems or management problems or screening problems or counselling problems. And so it's impossible to say, here's a model, we should be using it. But I think there are really, really good basis for registrars to sort of understand the background. We are not going to talk about the nuts and bolts. And I guess I only include this because I know registrars are driven to learn this. They're driven by data acquisition. They're driven by which bits of information to take, by physical examination, by which investigations to use. When we tie these 3 things together and more, we start talking about clinical reasoning, how data is gathered, how data is synthesized, how data is interpreted, and how data is expressed to the patient. And we're not going to focus on clinical reasoning. It is a consultation skill, but this is the money. This is what you guys have come along, and that's the tools, how to build this thing, how to actually construct, put together the bits of data, use some kind of plan to say, we've built a really nice, neat consultation, and we can replicate that a couple of 100,000 times over the next few decades. That's what registrars will value. I would really like for you to have a think about what are the key tasks of the consultation. So perhaps a medical student, a registrar, sitting on your couch, watching you practice, and they say, you know, you do it so effortlessly, and it's great to see you consult. But if you were to sort of unpack the thing, you know, how would you describe the key tasks of the consultation? And you might say, well, there's this guy called Roger Neighbour, and he said, we need to housekeep, and we need to safety net, and we need to hand over. What do you see as, you know, those tasks, those elements that make the consultation flow? Because one of the key observations we make, in fact, possibly the key observation we make of more junior registrars, is a lack of structure.
For me, certainly, yes. And I think it can often then influence how well all the other elements of the consultation, you know, flow out. If there's a poor structure where the history is sort of broken up by various other parts, then the history itself can then become poor. And key tasks of the consultation, and the first one is get the list out early on, which I think for me as a registrar was probably one of the biggest things I had to figure out how to do frequently. Building the rapport, assessing the patient agenda, so I guess that ties in with the lists. Listen to what the patient is saying. Active listening, that's another one that I think I've seen a lot of registrars struggle with. They're thinking about what they need to do rather than really listening to the patient. Motivational interviewing. Yeah, there's a lot about patient agenda, getting the list out, active listening, you know, allowing the patient to talk for the first part of the consult. The ideas, concerns, expectations.
In thinking about lists, I always like that notion of triage, and it's a strange concept in some respects to think about triage, but I teach the notion of triaging problems. And to me, you either, so commonly I see this, registrars half buy into a problem. So for me, it's triage and I have to buy into it, or I'm not buying into it. And sometimes I see them go well beyond the triage, but well short of what constitutes good management, because they kind of get overwhelmed and run out of time. Themes are about patient-centered care. And we'll talk about some of this now. So much of what we're teaching you or talking about, we, in a sense, assume you're probably doing effectively yourselves. What we're really wanting to do is how to translate that to teaching it, because these things you've just listed are issues for registrars, no question. And the way we want to do that is to talk through this, what sounds an extraordinary titled document, but the Kalamazoo Consensus Statement. Now, Kalamazoo is actually a real place. It sounds like something out of a Dr. Seuss book, but it's actually a town in Michigan in the US. And presumably they got a bunch of experts along, like you guys, and put you in a room and said, what are the key consultation tasks? Now, this has a very strong communication flavour to it. So some of the things that might not see there are maybe professional practice and preventative health and clinical reasoning, indeed, really core consultation skills, but these are much more from a sort of communication perspective. And so that list, we're going to sort of unpack through the prism of a patient encounter. And I just want at this point to reference a really useful GPSA guide on supervising the international medical graduate. And why do I say that? Not because these communication issues and some of these consultation skill issues occur exclusively in this group at all. I think that it's pretty universal. Doctors who have trained in a country where English isn't first language, doctors who have trained in a country where the approach to patients is much less perhaps democratic or more authoritarian, more interview style than a conversation, may really struggle just by the nature of their training and experience to engage with some of these aspects of the consultation. And so I'd really encourage you, again, particularly if you're seeing and having registrars from overseas work in your practice who may be having some of these particular issues, to have a look at this guide. But it's time for a bit of a role play. And what I'd like you to do is to introduce you to Rachel. Rachel's a 28-year-old university student. She's seeing myself, Dr. Sam. She has no past significant medical history. She's otherwise pretty well. She's got no medications. And what I'd like you to do is to use this framework just loosely as you see the consultation unfold, and get a bit of a sense of how well you think Dr. Sam, who is a late GPT-1 registrar, when he engages with Rachel. One of the really important points I would encourage you to do is to, if you've got a pen and paper, and maybe I should have suggested getting that early on, but if you have one nearby, is to write things down. When we give feedback around observation of performance, it's unambiguous what somebody says. It could be a perception if we say, I thought this, but if it's actually what was said, and you can then use that in your feedback, it's actually incredibly powerful. So quotes are very good. We'll start our role play. So, hi, Rachel. It's really nice to meet you. My name's Dr. Sam. What can I do for you today?
Oh, hi, Dr. Sam. Yeah, I actually saw you last time I was here a couple of months ago for my pill script. But anyway, that's not why I'm here today.
Oh, yes. Okay. Yeah.
I just wanted to talk about some headaches I've been having. They're really troublesome, and I just can't seem to get on top of them. And I'm not really sure if they're hormonal.
How long have you had them?
I'm not sure though. They don't seem to be. Oh, a good 3 to 4 weeks, like maybe almost a month now. Yeah, and
where are they?
I'm just not sure what's going on.
Yeah, where are they exactly? Sort of all over, or?
Yeah, like just kind of behind my eyes and around my head, kind of just everywhere, but mainly all around.
Yeah.
Yeah, the
and
front of my head.
Anything that helps them?
Well, I've been taking Panadol and Nurofen, and yeah, they help, but it doesn't really go away, and they're just sort of still going, and yeah, I'm just not quite sure why.
And do you feel stressed?
I mean, yeah, I am stressed. I've got a really busy job and a lot of deadlines at the moment, and we're short on staff. So yeah, I mean, it could be stress. I mean, I was wondering if it was perhaps my blood pressure, because there is a history of that in my family, and I don't know, I think sometimes blood pressure can cause headaches, but I don't know, I wasn't really sure if it could be that.
No, look,
they're just really going on all the time.
Yeah, no, it's a good thought. Blood pressure can cause headaches. Look, I should check your blood pressure. So pop your arm out there and I'll have a...
Yeah, thanks. No, I want you to check it actually, because I'm...
Oh, that's actually normal. Your blood pressure is good. But while I'm here, I'll just have a look at your eyes and just check your pupils there, and I'll do my best to have a look at the back of your eyes.
Yeah.
And that's all pretty good too. Look,
okay, that's good.
Rachel, I think this is likely to be a stress headache. It's common. We see this commonly. It sounds like you've got quite a bit on. I think, we probably can get on top of it with some simple pain relief, trying to reduce your stress, maybe get a massage, sleep, avoiding coffee, too much coffee and alcohol.
As I said, I am stressed, like work's busy, but I've certainly had way more stressful periods in my life, and I don't know, I've never had the headaches go on for this long, like maybe for a day or two, but I've had to have, Panadol and Nurofen almost every day. They take the edge off, but it just feels like it's more than what I've had when I've been stressed before, and that's why I'm here, because they're just not going.
Look, I better ask a bit more. Tell me, do you ever wake with the headaches? Do you vomit? Do you have any sort of weird pins and needles, numbness, weakness, anything like that?
No, I haven't had vomiting or anything. Like I haven't been sick like that. What was the first question? Waking? No, they didn't. No, I don't wake up with them. They kind of build up over the day generally, I think. And no numbness or anything. Yeah.
Well, they're the sorts of questions I like to ask, just to try to make sure there's nothing too bad. And I think it is likely just to be stress. I mean, I know you might not draw that connection, but it's very common for people to have headaches when they're stressed. And
do you think it, because obviously last time I was here, I got the pill. Do you think it could be from that? I just asked because one of my friends had to stop the pill because she was getting headaches. They said it was dangerous or something like that. That
Yeah, well, it's a good thought. Tell me, is it like one side of your head pounding ever? Do you ever get weird sort of things in your vision,
no,
flickering
it's more like
lights or anything?
around, around the front of, yeah, it's not, I don't know, sometimes it's pounding, but not really. I don't get flickering stuff in my
Yeah.
eyes.
And does
Yeah, I don't
anyone
get any of that.
get migraines in the family?
I don't think so. I'm not
Okay.
sure.
Look, I do think it sounds like a stress headache, and I was just looking up a couple of things. I think probably physio is going to be really helpful for you. Maybe, some neck exercises and, just try to reduce the stress in your life.
Yeah, I mean, I do try and meditate and stuff like that to manage the stress. It's just, like I said, I feel like, yeah, like I'm stressed, but I've been so much more stressed before, and I've been really much more busy with work before, and I've never had the headaches go on this long. And I mean, I don't know, like I came here because it's been going on so long, and I wasn't sure if like I needed a scan or something like that.
Look, I don't think so, but we can always do one if it doesn't get better. I reckon that's the plan. We'll certainly sort something if it's not getting better. So come back if it gets worse or doesn't go away, and I reckon it'll settle. Thanks,
Okay,
Rachel.
all right. Okay, thanks, Dr. Sam.
Possibly no prizes there for acting, but we are going to kind of unpack this using the stages that the Kalamazoo consensus statement refer to. You didn't see him preparing, but neighbours housekeeping, to use one of the points from one of the models, is very much preparing for the next patient, not just if you've had a tough emotional session breaking some bad news to someone and feeling ready, but knowing what the patient possibly presenting for, whether they were seen recently, checking any recent results. And we've all had personally experiences of seeing patients and realizing that they've come for the results that we weren't aware were in the notes, or that they've just seen a specialist and in fact we hadn't been prepared to see that letter. I mean, the challenge is saying, yeah, look, he was maybe really poor in some areas, but how do we give that feedback to him? How do we not knock his confidence? Were there any areas that actually were reasonable? And I guess when we think about the elements, we're not really thinking about the overall structure. And again, perhaps I'd ask, how do you address this sense of structure? What did Sam do that made it so unstructured? And more importantly, what could you do maybe to encourage a greater structure in that consultation? Yeah, I'm really hoping that you're not sitting there thinking that was so far removed from what's real, because certainly it's not so far removed from some of the consultations I've seen more junior registrars who are struggling perhaps undertake.
You were sort of polite on the surface, but you interrupted a lot, didn't allow the patient to sort of say their first minute or so of the consultation, didn't really consider, or, often missed several of my cues that I was concerned about particular things, and sort of just didn't seem to have Rachel's concerns at heart, I think. Yeah.
And maybe it's interesting to think about why I did that. This can be a really interesting conversation with a registrar to say, these are my observations. And it might be because Sam isn't rude or disengaged or not actually interested in what Rachel's thinking, but, they're actually just got this focus. I've got to get to the end point. I've got to get the questions out. I'm so focused on this that I can't sit back and listen. And that whole notion of active listening and genuinely hearing and responding to the questions, they've just got their next question to ask. As I did say, this isn't unique to international medical graduates, but some of that cohort have been trained in a very much a sort of interview style of, essentially, I'm here to gather lots and lots of data from you, and I've got a kind of interview process. And that is worth identifying, of course, and then being able to try to sort of socialize the encounter so that it is very much more a conversation than a data gathering exercise.
Building the doctor-patient relationship, and the fact that Dr. Sam hadn't just quickly checked the past visit, would have avoided that embarrassment and, that impact on the rapport about appearing to have not remembered her from her previous visit.
And you have really simple point tips about writing key information into the comments section about, recent bereavements or, relative of someone else, so that can be not forgotten. again, just really flagging some of the important elements that we know registrars struggle with and that you can really hone your teaching. The way we intend to do this is to flag the Kalamazoo statement, in this case, building the doctor-patient relationship. And I think often that's considered to be rapport building, and that stops after a minute or two, and then you get into it. But of course, it's really all the way through the consultation. Then there's some of the elements from the statement: greeting patient, builds rapport, shows concern, all stuff you know. But then a form of words. And it's, again, a really important teaching point we'd like to encourage you to do is to help registrars with the form of words. These are the words that I found really useful in my experience as a GP. Just excuse me while I use the computer to take some notes, rather than just turning to the computer. As medical educators preparing registrars for their exams, the first question, as opposed to a closed-ended one, is tell me more about it, which Dr. Sam didn't do. Opening the discussion. Any specific comments that you heard Dr. Sam say or observations you'd make?
Not allowing that sort of golden minute at the beginning of the consultation, too many closed questions too quickly and interrupting the patient.
We can encourage registrars. It's so important to sit quietly and listen. But I would encourage you in educating registrars to then say, how's that going to make you feel? And do you see any barriers to that? And let's role play it and we'll give it a crack. And it can be really tough to sit there and listen, particularly when the patient sounds like they're rambling or they're not going to get to the nub of it. And you're just wanting to know, how long have these headaches gone for? Because if it's been 6 hours, it's very different to 6 weeks. But just sit on your hands. And so I think getting behind the issues when we're educating registrars can be really useful. So data gathering, we haven't talked specifically about history-taking skills, but was there anything particular that came up around use of closed, open-ended questions, clarifying issues, active listening?
The structure of the history and that it was interrupted, repeated questions and not actively listening and that sort of.
So, Jess, you've sat in with registrars in the past. You've seen, I would agree, I think the data gathering was erratic, back and forth. How would you talk to a registrar, say, about a more structured approach to that, at least that aspect of the consultation?
Yeah, I think it's tricky because sometimes registrars, they lack structure within that history, examination, formulation, explanation. But then also if they're trying to deal with multiple issues in the one consultation, then they end up blending them all and jumping between them. So it sort of depends on what specifically where the registrar's issue is, but sometimes just, reminding them of the basics. Like sometimes I find with some registrars who are really struggling with getting a very basic history structure and they're forgetting stuff, is have an autofill that you have and you have to populate the answers, but if it allows you to get through the basics of what the red flags are for headache or something like that so that you're not forgetting those things. I don't know, I find the structure thing is actually really difficult to help people understand. Like I think that's when, you used to video registrars and they watch it back. It's kind of the best way for them to realise what's going on.
They're really well-made points. We all get to partway through our management planning and think, oh gosh, it's really important to ask that. But I guess ideally we exhaust the history as much as we can before moving on to the next stage of data gathering. So I'm not teasing out these words and questions, but these are actually come from the IMG guide, and they're all available for you. Maybe some of the more strongly worded critiques of Sam's performance were around the identification of the agenda and understanding the patient's perspective and seeing the problem through the patient's eyes. I'm not sure if that was the case, Jess, but I suspect that was a very strong theme that came out.
I think structure works better when the person taking the history is actively thinking about the differential diagnoses to guide their structure so that the questions are purposeful. And I think that's really, an astute observation, because so many people, I think things like red flag lists are really helpful, but I think sometimes registrars are just going through an interview and thinking of the next step rather than it's good to just sit back and listen, actively listen to what the patient's telling you, think about the differentials, and then you'll have a much more succinct and comprehensive history. Rachel's concerns were sort of dismissed and kept going back to the fixation on the diagnosis of a stress headache because of Rachel's stress. And at the end of the consultation, not sort of seeing if Rachel's, ideas, concerns, expectations had been adequately addressed.
Yeah, I'm hoping certainly not to be characterising some of these issues in the IMG cohort. But again, this is an area that is known to be, and there's evidence to say, that practicing patient-centred care can be much more challenging for some particular groups of IMGs. And again, it's very much to do with the training often that's been received, and the way, the cultural differences. And so patient-centred care is often a concept that's quite unfamiliar. Even the sense of having a very flat hierarchical structure in the encounter is quite foreign to some doctors from different countries. So that genuine sense of what is this person experiencing, and how can I try to get into their shoes, is something we might need to spend quite a bit of time on. ICE is well known to you, presumably. I like to talk about ICE being both listened for, the words frightened or scared or fearful, but if those words are heard by us, by our registrars, bang, stop, what did you mean by that? But in the uncertain consultation, where there's real ambiguity and it's hard to know where it's going, actually stopping and saying, I'm going to ask you a couple of questions, so this might really help direct things.
The difference between the biomedical model taught at med school, that very history, examination, investigation, management, versus the more patient-focused consultation in primary care, which, often explores the patient's reason for attendance driven by that ICE concept. It's very true.
Yeah. I am really pleased this appears in the Kalamazoo consensus statement, because I think there's very few teaching visits that I attend with registrars that I don't identify this as an issue. And this is this whole notion of the explanation, sharing information. And there's a couple of points I think registrars often fail to do well. Very commonly, they may data gather well, they may form a nice management plan that's safe and effective, but the bridge between those two just doesn't exist. They don't give their provisional diagnosis. At no point did Sam say, I think there's a thing called a tension headache. At no point did Sam say, that's because you're describing this typical type of headache and you're a young, otherwise healthy person, and it's got that classic presentation. And at no point did Sam say, and there are other things I'm considering, like migraine, and maybe even things more sinister that you might be worried about, but I'm really not concerned because of X, Y, and Z. Explanation supported by clinical reasoning with the differential diagnosis. Of course, where it's appropriate, you might need to be circumspect at times, and we're able to include the patient's ideas and concerns. That is true sharing of information. And it also may be part of our role as swamp warriors. If anyone knows Louise Stone, a GP from Canberra, who talks about living in the swamp as GPs and wading through this murky environment of uncertainty, and a bit of a flag for our guide on managing uncertainty. It might also be around sharing uncertainty with our patients. It could be anything, the way to general practitioners. So perhaps not as broadly as that. I think this is one of the absolute standout areas that registrars will gain from your input around how to put together an explanation that includes provisional differential diagnosis, the registrar's reasoning, and the patient's concerns. So reaching agreement maybe is the extension of the explanation, shared decision-making, inclusion of the patient. Rachel, did you feel that you were included in my management plan, or was I, as the doctor, more imposing this on you?
No, I think much more doctor-centred.
I think so. Jess, I know this is an observation that you've made in your role as an educator, particularly possibly with your background in paediatrics, that of effective follow-up and safety netting. The notion that, I think Sam in that instance said, come back if you're not better, but there's some very, very good evidence around what constitutes effective safety netting. I'm sure that came out. It's about Sam's performance. Can I point you to this excellent paper? It's about 3 pages long, so it's very easy to read and apply, written by GPs from the British Journal of General Practice, now a while ago, but still incredibly relevant. And really, print this off or give the link to your registrars to read. There's nothing more effective to help one sleep at night than being able to safety net appropriately. And so commonly, again, I see registrars who are just vague about when to come back. It'll help them and it'll help the patient if it's a bit more clear. In summary, I guess what we've done is talk about building this shack, this consultation. And it still strikes me as fairly extraordinary. And I've forgotten, how can we build this thing? How can we undertake hundreds of thousands of consultations without a clear way of approaching them? And I know after time and lots of mistakes, people make their way. But I think it's such an important aspect of what we do to move away from knowledge-based learning, which registrars can pick up in a textbook or ETG, and move towards skill-based learning, how to reason, how to be a professional doctor, how to communicate well, and how to run a consultation. I really just raise the prominence of this not just being sort of the accidental aspect of what we're doing, but, pretty much everything. This is the kind of, the absolute prism by which we should be doing all our teaching. How did that consultation run? So, by way of resources, I've already mentioned the GPSA Consultation Skills Toolkit. Jess made, I think, a very astute point. I know what's in that because I put a lot of that together, but there's still nothing really kind of succinct about structure. And often it is up to us to kind of see enough consultations of registrars and try to work out where it's falling down in terms of structure and try to kind of use some of the tips that we've discussed. The college curricula variably will talk about consultations. I spoke to Greg Gladman from ACRM. They don't have a particular model that they ascribe to using in teaching. And similarly, the RACGP don't say this is the model that's more effective. But if you're going to think about something that's globally pretty useful, I think Ron Roth's approach is really nice. There's me in younger days, and it's almost 10 years ago now that myself and two colleagues here in Newcastle wrote this paper that you may know of. This isn't in any sense to big note myself, but we were really excited to think we were just sort of mucking about as medical educators here in Newcastle, putting together a session on what might be useful for registrars as survival skills. And this paper has been really, really popular, used by educators and supervisors. So if you're not aware of it, again, this is about you teaching, but it's absolutely about the registrars picking it up and applying it. We've got a couple of guides which don't directly refer to the consultation development, but they certainly allude to it, the practice-based teaching guide and how registrars can plan their learning. And I also talked about the teaching plans. You may know of them. There's lots and lots of them, as you can see, on various clinical topics, but there are also, I think, 15 or so on consultation skills and literally how to reason, how to follow up in safety net, how to take a good history or rationally prescribe or order tests effectively or physically examine the patient. So have a look at those and certainly use them in teaching and point your registrars to them. And the two supervisor guides, again, point towards the consultation, not as strongly as I'd like, but it's nice to think that it's becoming more and more prominent. We do love your feedback. Thanks so much all. Bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.